share your screen. Oh, there we go.
So do you see my screen?
Yes, we do. Thank you so much. Go ahead.
Thank you very much, Emad, for the kind invitation. It's my pleasure to be with you today and Prof. Bhandari. And we really have been enjoying these fantastic series of Endo Orbit, which have been really highly educational and touch hot topic in endoscopy, spreading the knowledge, awareness, and skills. I will be talking about why patients with GERD should be treated. And as we all know, GERD is a condition which develops when the gastric content reflects into the esophagus, causing troublesome symptoms or complication. The symptoms can be either esophageal or extra-esophageal in nature. The updated line consensus has refined the objective evidence of GERD, which previously include only grade C and D in a esophagitis, but now also include grade B, in addition to biopsy-proven barred esophagus and peptic stricture, in addition to abnormal parameter on the esophageal reflex monitoring. As we all know, GERD is a highly prevalent condition worldwide, as you can see this in this map, but you can also see that Saudi Arabia in the center has the highest prevalence of GERD worldwide with more than 35% prevalence. In the United States, according to the study from 1997, they found that about 20% of the US population they report at least weekly episode of GERD symptoms. A newer study from 2020 based on the population-based survey, they found that 2 out of 5 individuals, they ever had GERD symptoms, and 1 out of 3, they had GERD symptom in the previous week of the survey. Here in Saudi Arabia, we have multiple studies that looked at the prevalence of GERD. These studies were mostly based on the GERD-Q questionnaires, although they were not really randomly selecting a representative sample of the Saudi population, but the prevalence found in those studies were between 23% and up to 45%, which is very high. If you look at the risk factor for GERD in the Saudi population, they are very common. 23 of the Saudis are obese and 40% are overweight. And we know that obesity is a major risk factor for GERD and its complication. The problem is even further complicated by the fact that the common obesity interventions are actually associated with GERD, such as the GLP-1 receptor agonists, which can be associated with delayed gastric emptying and therefore risk of development of gastroesophageal reflux disease. The most commonly performed bariatric surgery, which is the laparoscopic sleeve gastrectomy, is associated with the risk of continuation of GERD post-operatively, in addition to de novo GERD development after surgery, which is a major issue that we are dealing with these days. In this study, the GERD was seen in about 74% of patients after sleep, and this was based on an objective parameter, including reflex esophagitis, grade B or higher, in addition to abnormal reflex pH monitoring. About 17% of Saudis smokes, and we know smoking is also a risk factor for GERD and its complication. And unhealthy diet is highly prevalent, especially with the busy life these days. Everybody is just eating fast food and drinking coffee, and both are risk factors for GERD. Hiatal hernia, a major risk factor for GERD and barred esophagus and esophageal cancer, is present in about 28% of patients who underwent endoscopy for any indication. This study was done in our hospitals, and you can see the prevalence was not dependent on the gender, age, or BMI, and this prevalence is actually quite similar to the study done elsewhere in the world. When you look at the extra-esophageal GERD symptoms, including atypical symptoms, about 1/3 of patients with GERD, they may have atypical or extra-esophageal symptoms. Non-cardiac chest pain about 23%, and lung manifestation, including bronchitis and bronchial asthma, We have also hidden symptoms, including voice hoarseness and global sensation, in addition to dental problems. And now in everyday clinic, we are facing patients referred from ENT doctors having some throat issue, and a significant proportion of these patients, they actually have GERD. This study looked at the extra-esophageal disorders among patients with GERD, and you can see here, 32% of patients with GERD, they have any extra-esophageal disorder. These include chronic cough in about 13%, bronchial asthma about 4%, laryngeal disorder 10%, and non-cardiac chest pain in about 14%. So why should we treat GERD? Obviously, we want to relieve the patient symptoms. We don't want to leave our patient suffering. And if we do this, then we are going to improve their quality of life. And of course, we want to prevent GERD complications, which include reflux esophagitis, peptic stricture, Barrett's esophagus with its own need for continuous surveillance and the risk for esophageal adenocarcinoma. And we also want to prevent extra-esophageal complication. The quality of life among patients with GERD is actually much lower than the general population. And you can see in this study that GERD not only causes symptoms, but it causes emotional distress, sleep disturbances, inability of our patients to enjoy their food and their drink, and they also cause some social dysfunctioning as well. And you can see in this graph as well, after patients get treated, their quality of life actually increase. This is another study that looked at the effect of GERD on the work productivity, and you can see here, GERD is associated clearly with decreased work productivity, and such decrease will increase with the severity of symptoms. Those with more severe symptoms are much more likely to have decreased work productivity. We cannot forget to talk about nocturnal heartburn. Our patients are suffering at the bedtime, and nocturnal heartburn has been associated significantly with reduced productivity. And if you can look at the relationship between GERD and sleep, and we can find that GERD can affect sleep in multiple domains, including difficulty in falling asleep, nocturnal awakening, early morning awakening, and overall, these will result in poor sleep quality and hence decreased daytime productivity.
Yes.
This is a multi-European study that looked at the quality of life in patients with GERD, and you can see across all countries, GERD is associated with decreased quality of life and decreased or increased time lost from work, and this will translate into economic burden. So what happened to our patients after we treat them? You can see here that the black column are patients with GERD who at baseline before treatment. The gray, dark gray columns are those who got full response to PPI, and the white gray or the lighter column is those who got partial response to PPI. And the continuous line, this is the general population means for quality of life. And you can see here, after we treat our patient, we improve their quality of life to, that is similar to the general population. Reflux esophagitis is a common complication of GERD and can be classified into 4 different grades, and it can be associated, if untreated, with peptic stricture, Barrett's esophagus, and the risk for esophageal adenocarcinoma. And we can see that the prevalence of reflux esophagitis is variable depending on the nature of the study, whether the patient who have been studied got symptoms or no. And that prevalence varied from 6% to 29%. In our population, this is under review. We looked at all our patients who underwent endoscopy for any indication, and we found that 11% of those patients, they have reflux esophagitis. And when we only looked at patients with GERD indication, 25% of those patients, they have reflux esophagitis. And obviously, most esophagitis were actually grade A or grade B. This is a nice UK study which looked at the incidence of peptic stricture with the introduction of PPI back in 1994. And you can see here that the incidence of peptic stricture has dramatically decreased over time with the wide use of PPIs. What about Barrett's esophagus? So this is a systematic review that included 49 studies. The overall risk of Barrett's esophagus in the low-risk populations of about 0.8%, but that risk increased to 3% in those with GERD. And if they got GERD plus other risk factors, the risk would further increase up to 23% if they got family history. Here in Saudi, Barrett esophagus is not common. And this is a study that I co-authored with Dr. Emad, and you can see here that the prevalence of GERD in our Saudis among all patients who underwent endoscopy was 0.64%, and it is significantly more common in male compared to women. Now, if the patient got Barrett esophagus, then there is always the risk of developing dysplasia and moving from the low grade toward high grade and cancer. And this means that these patients need to be continuously followed for surveillance and treatment if applicable. This is a nice study from Pratik and his group. They looked at the healthcare utilization and cost in the United States for patients with GERD. And you can see here that among patients with GERD without any other complication, they cost around $6,000 per year. And that annual cost will increase to up to $145,000 if they have developed esophageal adenocarcinoma. So what option do we have to treat our patient? We have the diet and lifestyles. We have the medical therapy, among which PPIs are the most commonly used and the most effective. And we have the primary surgical options for GERD, including laparoscopic fundoplication and magnetic sphincter augmentation. And then we have emerging endoscopic options that we are all becoming more aware about. So a lot of dietary factor and target can induce GERD through different proposed mechanism, whether through the reduction of the lower esophageal sphincter or perhaps increase gastric acid production. We spend time to educate our patient about diet and lifestyle modification, but what really happened that patients, they don't adhere very well to these recommendations because patients, they want to enjoy their life. They cannot just live lifelong having a complete restricted diet. The study found that actually patients with GERD consume many GERD-provoking foods similar to those without symptoms. Although PPIs is the most commonly used treatment method, our patients now are becoming more concerned about the safety profile for PPI. They're hearing side effect and association all over the social media, and this becoming a constant question in our clinic these days. Although most of these associations are weak and they do not represent a cause and effect etiology or relationship, but the concern will not be eliminated by such a statement from the ACG guidelines from 2022. Furthermore, about 1/3 of patients do not respond to PPI, either fully or partially, and there are multiple reasons for this. One of them is actually true PPI refractory GERD. So we really want to have other options to treat our patient. These are the primary GERD surgical options, which include the laparoscopic fundoplication, either complete or partial, and the magnetic sphincter augmentation, which has emerged since 2007. But you can see here that the efficacy for laparoscopic fundoplication, which is considered the gold standard, is not optimal, with 10 to 20% of patients going back to PPI in 5 years. And patients also concerned about the risk of having dysphagia, gas bloating syndrome, inability to belch or vomit. And with regard to the magnetic sphincter augmentation, the data available in the long term is limited, but what is available suggesting a similar efficacy to laparoscopic fundoplication, but also with the risk of dysphagia, a low risk of device erosion about 1% or less, and issue with MRI compatibility. So what happened after anti-reflux surgery? So you can see this is a Danish population-based study that looked at the long-term use of PPIs after anti-reflux surgery. And they found that more than 50% of patients who got operated, they became long-term PPI users 10 to 15 years after surgery. So even surgery is not even the best. However, the current data supports surgery as the most effective intervention. And in certain patients, this is the only available option. This is 2 patients of mine. First one got a large hiatal hernia with a long segment Barrett esophagus, was sent for our surgical colleagues to undergo hernia repair and laparoscopic fundoplication, and she's doing very well. But obviously, she needs to continue the BPI, getting the bad esophagus. The second patient, becoming a common scenario these days, patient with GERD post-sleep, and this patient underwent legs procedure by our colleague, Dr. Ashraf Marabi, who was really a true leader in this field, and she's doing very well. However, after all, we need to have more innovative, minimally invasive intervention to help our patient. And we need to understand that the anti-reflex barrier contain or composed of the pleural of the diaphragm, the gastric esophageal flap valve, and the lower esophageal sphincter and sling fibers. We need to understand this in order to select the best treatment method for our patient. And we need to spend time assessing the gastric esophageal junction during endoscopy. These pictures are actually from the same patient. And you can see from picture A, this almost looked like Hill grade 1, but with more air circulation and waiting for 30 seconds, you can see this patient clearly has underlying hiatal hernia. And this is the laparoscopic image from the same patient showing a big defect in the diaphragm. We now use Hill grading or TILI to assist our patient, particularly those who underwent endoscopy for GERD. This was further refined by the American Foregut Society classification, which include now also the axial length of the hernia and the hiatal opening as well, in order to select the best treatment strategy for patient. The endoscopic intervention for GERD are evolving, and these days, transoral incisions fundoplication and GERDX represent the most widely utilized options. The other options include the anti-reflex mucus ablation, mucosal ablation, streta, anti-reflex mucosectomy, and fuse. And the fourth at the bottom of this slide, they have limited data or some question about efficacy, limiting their wide spread. Our team at King Abdulaziz University Hospital has been leading with GERD management, given the burden of GERD in our society. We have been rapidly adopting this new technology and working closely with our surgical colleagues to identify the best treatment strategy for our patient. And we're grateful for our surgical colleagues and our team in the endoscopy nurses, our anesthesia team, and our GI fellow as well, who have been supporting us treating our patient with the right strategy. This is the first patient that we treated at our hospital with GERDX. He was a 33-year-old nurse who got chronic troublesome GERD symptoms. He got partial response to traditional PPIs, but a good response to only 60 milligrams of Dixieland. But even with this, he would still get some occasional regurgitation. It was very clear that he was not interested in having surgery, but he was willing to try endoscopic methods. So we performed the first case of GERDX in January of 2022, and the patient was discharged 3 hours after the procedure, and now he has completed 25-month follow-up. He's doing extremely well without needing any anti-acid medication. And with that, I will conclude my presentation. So GERD is a highly prevalent condition. GERD significantly impacts the patient quality of life. GERD should be treated and prevented if possible to relieve the patient's symptoms, to improve the patient quality of life, to prevent GERD-associated complication, and to reduce the healthcare utilization and cost. The ideal treatment should be cost-effective, non to minimally invasive, safe, and durable. And with more options becoming available, patient selection is the key to have the best possible outcome. And thank you.
Thank you, Majid, for this great presentation. As a matter of fact, you highlighted nicely many of 1 second. Okay. Can you stop sharing from your end, Majid, please?
Okay.
Okay, thank you. So, thank you, dear Majid, for actually highlighting this. Now we can just gonna go over a few comments that you have made actually in your conclusion, and I would like to really just support the way GERD can affect our patient's life, social life, work productivity, sleep patterns, and so many issues that can actually be affecting them on the daily basis. On top of preventing cancer, of course, Barrett's esophagus is one of the major issues, though we don't see it quite commonly. But as you may think the same, we are kind of maybe not screening our population quite well yet. Maybe at the or some of that. Why do you think our population, despite having almost the same or similar lifestyle of the Western population, adopting much more fast food, obesity has become a major burden within our patient population? Why do we still not appreciate Barrett's the same level that we used to appreciate it during our years of training in the West? Do you have any comment on that? And then I'm going to take Dr. Pradeep to comment on some of the points I have.
Okay, thank you, Emad, for this great point. I agree totally with you that we're not seeing parity in Saudi, or not used to see it in Saudi as we see it in the Western country. But I understand, as we discussed before, that part of this related to maybe to under recognition of Barrett and not looking carefully to identify patient who got Barrett esophagus. That's an issue. Second issue, the change in the diet and lifestyle effect that maybe we're going to see it in the next decade or so. So we're what being seen in the West, we are going to see it, but maybe we are lagging sometime after them.
Okay. One of the questions here actually saying like when will this technology will be available in Saudi Arabia? Actually, it is available and being conducted in different parts of the kingdom. So if you search for it, you will find one of the nearest centers available. Prof. Pradeep, Prof. Bhandari, I would like to ask you now, now in the era of having a less invasive procedure, such as Endoscopic and as well as GERDX, do you find it convincing that we should, to some extent, offer that to our patients beside or just after you recommend the lifestyle modification, and if they have failed after a few weeks of trying that, would you straight ahead recommend that if they are candidates?
Thanks, Emad. I think first, I just want to comment on the Barrett's prevalence, why you don't see there that often, because I think you're genetically protected. Western population is genetically prone to getting Barrett's, so we were lucky that your genes are protecting you. But the lifestyle is changing so rapidly that it is coming. It is coming. Obesity and lifestyle will bring Barrett's. Wherever KFC and McDonald's have gone, Barrett's has followed in 10 years. So it's only a matter of time. Whether we should be offering this minimally invasive endoscopic treatment to everyone, my first thing is, yes, we should all give lifestyle advice to patients, but that doesn't work. It doesn't work. It doesn't mean that we shouldn't advise them to stop smoking and stop drinking less fizzy drink, but honestly, it doesn't work. So what do we do after that? Should we go to PPI or surgery or endoscopic option? I think it's a bit unrealistic to think that we can do surgery or endoscopic anti-reflux for everyone, because the population of reflux is huge. So many patients. Yeah, but if I were a patient, what would I want? Me as a patient, I suffer from reflux and I take PPI. And to be honest, whenever I travel, if I forget to take PPI with me, and which happens quite often, I suffer. And it does. It's very annoying. You have to give a talk, you have to prepare, and you're feeling terrible. You haven't had full sleep, jet lag. It's just reflux. It sounds very, it's benign and it doesn't have any serious consequences, but it really kills your quality of life. So if it were me, I would prefer to have a minimally invasive option, knowing very well from the surgical data that no option lasts long term. So I think reflux, all the management options are like a, how do I describe? It's a spectrum. and you start maybe with lifestyle, with PPI, with endoscopic option, with surgery. So my honest feeling is, if we can delay the surgery, it's better, because surgery is not a lifelong fix. As you quite nicely showed, that in 5 to 6 years' time, a lot of patients who had fundoplication end up started taking PPI. So it doesn't last. So our intention should be to delay the surgery, whichever way we do. The endoscopic
or even
option.
avoid it, or even avoid it.
Yes, well, if we can avoid, that's best. But my gut instinct is, just like how after 5 to 7 years, surgery becomes less effective, similarly, even endoscopic options that we have today might also, their performance might also deteriorate with time. Although at the moment, the data doesn't support what I'm saying, but I think that's the natural way it goes.
Absolutely. So I have two questions about the GERDX device itself, which will make us go ahead with your presentation kindly. Prof. Pradeep actually is gonna tell us more about his experience with the GERDX device, which will be demonstrated on the live case once we're done with it. Prof. Pradeep, the mic is yours, and please go ahead.
Thank you. So let's share my screen. Okay, where is my talk? Here we go.
And I really would like to thank you for joining us today.
Pleasure. So I hope you can see my talk. Yeah?
We can see it. If you could just expand it to a full screen.
Yeah, let's.
There we go.
That's better, yeah? Good. Okay, so good morning from here in UK, good afternoon in Saudi. I'm sure people are joining from all around the world, so somewhere it will be good evening and good night, guys and girls. So it's a real pleasure to join you. GERDX is an exciting device, and we have both Isofix and GERDX available in UK, and they are slowly making inroads into the management of reflux. These are my conflicts. And I'll try to address the current state of affairs with reflux, the anti-reflux mechanism, which I think has already been illustrated very well, and then focus on GERDX. So there is so much data about reflux. The exact and the true prevalence of reflux, it probably is not known, because a lot of reflux is unreported. But we do know that the incidence is huge, and about less than 1% of these patients actually end up having surgery or have access to surgery. So majority of the patients right now do not have access to surgery or do not want to have surgery, or surgeons can't afford to operate on them. So the gap in the market is huge, which is being filled in by PPI, but there are lots of downsides to PPI. One of the other things I want to highlight is this interesting study, which shows that almost 60 to 70% of reflux is non-erosive reflux. So unless you do pH studies, you will not know whether they have reflux or not, because endoscopically they will look completely normal. They will not have hypertonia, and there will be no esophagitis. So that's why I feel that the true prevalence of gastroesophageal reflux is very big. And that's where I think a lot of patients are happy taking PPI forever. Some of them who have reflux have got access to surgery, but the gap still remains big between the two. You've already highlighted in the previous talk about the downside and the side effects of PPI. Having said that, none of this data is good enough to be very confident that these definitely are the side effects. But you constantly see people in your clinic who read in the press or some paper or publication which highlights the dangers of PPI. So public is getting scared of taking long-term PPI. The effects or the side effects can be related to acid suppression or unrelated to acid suppression. And we just need to be careful when patients are on long-term PPI, we should monitor them. Surgery is certainly very effective treatment, but surgery does have consequences, and a lot of patients do get post-surgical symptoms, which can be annoying. They are not serious. Surgery is safe, but it does have its downside. So it's not for everyone. And as I said, access to surgeon and surgery is also not that easy. So we are trying to fill in this gap between PPI and surgery. I personally feel we need to erode into the market of the PPI and try to move more and more patients away from PPI to endoscopic anti-reflux. And this is where, before we go into these anti-reflux mechanism, again, this is an overlap. You've seen this slide before in the previous talk, but it's important to understand the anatomical as well as the physiological anti-reflux mechanisms involved here, because that's how we can develop an effective and endoscopic anti-reflux mechanisms. So one of the things to understand is this, that the lower esophageal sphincter is not just the circular esophageal muscle fiber, but it is also includes these gastric sling fibers. So those of you who perform POEM, you would have seen these sling fibers. As we reach the LOS, you begin to see these sling fibers, and these sling fibers form an essential anti-reflux mechanism. And in my opinion, one of the mechanisms by which all these anti-reflux, endoscopic anti-reflux devices work is by strengthening these sling fibers and strengthening the flap valve mechanism. So a lot of options. We'll focus today on GERDX, which has evolved from plicator, which was the original GERDX, but then it evolved into the new GERDX. You've seen this slide before. What I want to say is that endoscopic anti-reflux treatment on its own is only applicable maybe up to grade 3, Hill grade 3. Hill grade 4, endoscopic anti-reflux on its own is not effective. So this is where GERDX started as a plicator from Endiosurgical. This was a nice device, but could only apply one single suture, and that's it. And it was a mechanical device with various wires and things. So once you applied, that was job done. With this device back in 2006, they showed the efficacy data at 3 months, both in terms of quality of life as well as PPI use went down with this. So the quality of life improved, PPI consumption went down. And then subsequently, there's 5-year follow-up data, which shows how this remains effective. Just the single suture with the plicator, showing that a lot of these patients stayed off PPI at 5 years. This is now evolved into GERDX, which is a hydraulic system. This is the distal end of the GERDX, where you can see your tissue retraction device comes out, the helix comes out, pulls the tissue in. As you close the arms, the suture gets fired. This is how it starts. You can see how sophisticated it has become in this video here. This is a very nice handle, very clear marking of what to do. This is how you perform the retroflexion. Then you can lock it. And then once you want to open, close, fire, all those things can be easily controlled from this handle. So it's almost, I would say, an idiot-proof handle, where all you have to do is, if you want to open, put it on open and open the device by pressing this. If you want to close, move that knob to close and press that handle and it closes. So if you want to close, you will move it to close and now press and it will close. If you want to fire the suture, you move it to fire and do the same. So it's incredibly easy to use. The way it works is we put a guide wire, put the GERDX device in, we push out the helix, pull the tissue into the two arms, suck, deflate. Once enough tissue is in there, you close. And once you're happy that you got the right amount of tissue in there, you fire. And then you open and take the device out, you reload and you go back in. So I'll show you one of the cases. You see, do the assessment. It's about grade 3, Hill grade 3. We put a guide wire. You thread the guide wire over the device. I personally prefer patient lying supine, but you can do left lateral. Once the device is in, you put the scope, pediatric scope or a transnasal scope. They both retroflex and position yourself near the cardia. Helix comes out, pull the tissue in, then deflate, so more and more tissue comes in. Once you're happy, you just close. So there's plenty of tissue in there. And now you fire. Once you fired, release the helix, open the arm, move away, and you see very nicely plicated. So happy with that. Then you repeat the same process with a second suture. This is the second suture, it's gone in, and you can see very nice. Look at that. When we go back in, it's quite tight, very beautiful wrap, and almost as good or better than the surgical wrap. So if you want to know a little bit more of what happens outside, as I showed you, the handle is very easy. Once the guide wire is in, you thread it over, you push, you put the device down. This can be a bit tricky. So sometimes you might need to dilate the upper esophageal sphincter. Once it is in place, then you put your pediatric or a transnasal gastroscope through the same handle. Now you retroflex using that knob. You go up, close to the cardia. Your scope is guiding you all the way along. Once you're in the right position, you open these arms, move the knob to open as I showed you earlier, and then you open. You then push your helix out, grab the tissue. Once the helix has grabbed the tissue, you can lock it in place. So a lot of safety mechanism built. So the people, so as an endoscopist, we don't need to worry a lot. The tissue is grasped, it's locked. Once it's locked, you're ready to close. You position yourself, move the knob to close, and then you just press the handle and it will close. You see, move it to close, and now you press the handle. As you press the handle, it will close those arms. And then all you have to do is fire. So it looks pretty simple and easy to use. I'll show you some data related to it. The first study came out in 2018 with 40 patients. This was their early experience. In this, they lost 10 patients, 7 of them because they went to have fundoplication at a very early stage. So they followed up these 30 patients, and you can see at 3 months, the Demister score, the quality of life, and GERD-related symptoms all improved. The reflux episodes went down, and the side effects were few, but this is an early stage where they had a couple of significant side effects, but overall, not much to worry about. This is the large randomized control trial performed by Nagi Reddy's group in Hyderabad, where they recruited 70 patients into a sham control trial. So we don't normally see many sham control device trials. So we got to thank them for sorting out a sham control trial. And at 3 months, you can, and 6 months and 12 months, you can see how in the GERDX arm, the quality of life progressively went up. whereas in patients in the sham arm, very small improvement in quality of life. The beauty is the procedure time was less than 20 minutes. So it's a very quick procedure with long-lasting benefit on quality of life. Similarly, you can see the episodes of heartburn, episodes of regurgitation, they all improved in the GERDX arm and kept on improving till 12 months. PPI use, yes, again, a big drop in PPI use in the GERDX arm as compared to sham. So again, big benefit. A lot of these patients can come off PPI. So pH studies, they also objectively try to confirm its efficacy, not just clinically. Interesting results on pH. There was some reduction and there was some improvement in pH, but not statistically significant. What we saw statistically significant improvement was in the number of acidic reflux episodes. And the conclusion of the study was that maybe it will not normalize your acid exposure time, but it certainly reduces volume reflux. And this is how patients are getting benefit, by a reduction in volume reflux. Very few side effects, very minor, very few side effects. So overall, a very safe study. This is an interesting one done by Amit Maidev in Mumbai. As you know, we increasingly performing POEM for patients with achalasia, and they then are at high risk of getting reflux. So Amit has done a randomized sham control trial in patients who had POEM for achalasia because they all have documented reflux. And again, at 3 months, they've reported reduction, significant reduction in the acid exposure time with GERDX. PPI usage, you can see, has dropped a lot in patients who had GERDX. And again, the quality of life got better in a large proportion of patients. And procedure time was around 25 minutes. So it's a quick procedure. It does work and looks safe. The side effects in this study were minimal. This is a recent meta-analysis looking at the same studies that I explained to you. So I won't go through it again in detail, but it comes to the same conclusion as the previous studies. So in conclusion, I feel that majority of reflux is non-erosive reflux, which doesn't get taken seriously by most clinicians because they don't see any obvious endoscopic changes, but patients do suffer. So please pay attention to them. A lot of these patients remain untreated or they do not want to take PPI. And as I explained, that very, very, very small proportion of them undergo surgery. So there is a big, big gap in the market and a big clinical need, unmet need, which can be filled in by GERDX. And I showed you that it's very simple, very safe, very quick, and effective procedure. Thank you very much, and would like to invite you all to Endoport in May. The weather in UK will be very good, and you should be able to see another GERDX procedure live and discuss with all our colleagues. Thank you very much. I'll stop sharing here.
Thank you, dear Pradeep. That was a wonderful presentation, just almost concluding everything we have to know about the GERDX device. And the matter of fact, before I proceed with my questions, I don't know if anyone from the audience, if you have any questions, do please share them in the chat box, and I'll be more than happy to direct them. So if I'm just gonna put sharing the pictures, excuse me, yeah, there we go. Okay, so I'm just also gonna put Dr. Majid in this discussion. So Pradeep, so many people, I'm just gonna ask this question because I know sometimes it's difficult really to direct to anyone, but I think you're capable, you have the experience, you have the foundation to really handle this. If you were given the chance or the option to choose between GERDX and another device that's available in the market, why would you go for GERDX specifically? It seems like you have made your choice and you're really very happy about it. So if I may ask that question.
Yeah, I think the choice of device that you use, I personally feel there are non-device options like ARMA and ARMS where you can do ablation. They are okay. Long-term efficacy is still not known and are only suitable for very small proportion of patients. So we are then left with two main devices, Isofix and GERDX. Both have equally good data. So I think if you, whichever one you're trained in, you should be using access, price. To me, GERDX seems extremely simple. The steps are very few and the procedure time is very short. So it's a very quick procedure. The device has been developed in such a way that the risk of you forgetting a step is almost negligible. It's so idiot-proof. You have to move the knob to close, only then it closes. You move it to fire, and then you fire. So it makes it very simple. You don't need to remember it in your head. The other devices are also good, very effective, and you can get similar results like this. It's just got lots of steps. So you got to remember that. That's the only difference.
I can tell you, I can assure you the other device is not as straightforward explaining itself. Dr. Majid, now I have some questions coming from the audience asking about using GERDX in patients who had an altered anatomy, such as sleep. Any take on this?
Okay, that's a good question. So we know that the sleep stomach is actually narrow, so it's not usually it's not possible to open the device and retroflex in order to see the junction. So it's not actually safe. It's not recommended at this time to be used in sleep stomach. Although there are some reports of sleep stomach actually somewhat sebaceous that you can actually open the device and retroflex, but I wouldn't recommend to go and try GERDX in a sleep stomach unless you see the stomach is actually big enough.
Absolutely. And so in that case, maybe you would recommend if the patient is obese and looking for something as an anti-reflux, would you suggest doing the endoscopic sleeve or laparoscopic sleeve? I mean, the fundoplication before the intervention for like sleeve, whether it's endoscopic or laparoscopic?
Yeah, so this is an interesting concept now that we do treatment for GERD at the time when we do the bariatric surgery. So we can do a combination of TIF or GERDX before the sleeve, or we can do it in like a combination of TIF GERDX before doing ESG, endoscopic sleeve gastroplasty as well. And there are some emerging data supporting that, but very limited.
Prof. Bhandari. So now we do know that some surgeons, before doing the anti-reflux procedures, whether it's any kind of fundoplication, they kind of happy or inclined to do the manometry studies, the pH studies. Whom would you recommend doing that, especially before doing GERDX? If any.
I think if we are going to put somebody through, the reason why surgeons do is in the past, when they saw reflux, patient had reflux symptoms, they went ahead, operated on them, and then found that the symptoms got really bad. They had severe dysphagia because they inadvertently treated some patients with achalasia. And that's when the protocol changed and it became a standard routine that everybody needs to have pH and manometry before we do this. In my views, I think pH study is a very good thing to do before you perform these procedures, because when patients come back and follow up and they have recurrence of symptoms, which sometimes may not be related to acid reflux, you need some objective data to say that there was reflux and your procedure has fixed that, and that's what your pH study will show you. And symptoms might or might not get better because the symptoms were unrelated. Now, that does become a bottleneck. In my own center, a lot of centers where I've traveled around, pH studies is not that easy to get done because the number of people doing is less. Waiting times are big. So we need to think carefully who will really benefit by PH or not. But at this stage, I don't think I can recommend that go ahead and do it without PH studies. What do you think, Dr. Majid?
Yeah, I do agree with you fully. In Saudi, pH is more widely available. And in most patients that we do pH before we do this endoscopic intervention, but a very carefully selected patient who is very reliable and with typical symptoms and completely PPI dependent, we stop PPI, they have recurrent heartburn, they take PPI, they are fine. In those patients, maybe I will not do the pH study, but for other patients, yes, we have to do. For manometry, it's not a routine requirement because this is
Right.
considered a partial fundoplication, not a complete wrap.
Yeah.
Okay. Sounds very good. So there was a question about number one, is it reversible? What are the complications? Muhammad Jamal is asking. Pradeep, anything you have encountered there as a complication, serious one?
I think the first thing to note is the GERDX doesn't stop you from doing fundoplication. So whenever we start doing new things, we always need to think like what will be the ultimate game here? If this fails, doesn't work, am I screwing up patient's future for having surgery? It doesn't. Why would you want to reverse? I'm not too sure. If you already have a documented reflux patient, you did the procedure, I'm not sure you need to reverse it. The question is, if GERDX doesn't work, what do I do? You don't need to reverse. You can send the patient to the surgeons. They will do the fundoplication.
That's interesting. So, Majid, also one of the audience, our dear guests, actually are asking about, is it Saudi FDA approved?
So the GERDX is Saudi if they approved, yes, but I don't think it's yet approved by the American FDA.
Okay. Okay. So it seems like we don't have any more questions. Any comments, Prof, Pradeep, Majid, anything you would like to say before we go on a short break and start the procedure?
My comment is reflux is very common, has been underdiagnosed, undertreated, partly because the only option was PPI and surgery. Now that we have 2-3 very effective endoscopic treatment available, I think more are coming, I'm aware. So this area is going to explode. It's an area of growth, and I think we should embrace it.
Majid, anything you would like to add before we move to the live
Thank you,
case?
Emad, and thank you, Prof. Bhandari. Just a question for Prof. Bhandari. I want to know to what extent you would do this endoscopic intervention in someone with a very small hernia. I saw from his lecture that he wouldn't recommend beyond Hill grade 3, but would he do it for someone with, for example, small hernia, or he will discuss with the patient that efficacy is maskless? So I want to know his approach for those patients.
Yeah, no, it's a very good point. The thing is, these devices are expensive. They're not cheap. And we need to be very careful when we're selecting the patient that it works, because if it doesn't work, the device, the procedure, and you yourself, all of us lose our reputation, our value. So that's why patient selection is key. So ideal candidate is with no hiatus hernia, non-erosive reflux, who doesn't want to take PPI. That's the best possible scenario. After that, you can push your boat out to maybe up to 2 centimeter hiatus hernia, but always have that conversation with the patient to warn them that the efficacy, it has been shown to be effective and it is most likely going to work, but may not work. So if they would like to consider surgery, I'm very open-minded, because when I offer treatment to somebody, I don't want the patient coming back and telling me that I spent so much money and it's not working, I'm still taking PPI. So having that open discussion right at the beginning is a very, very good idea. And then patient can make their own choices. And when I've done that, patients who had 2 centimeter hiatus hernia still said, no, doc, I want to go ahead with it. I don't want surgery.
Great.
Thank you.
So with that, we're going to just have a short break before we start our live session, and looking forward to see you.
Excellent.
5 minutes. Take care.
Yeah. See you in a minute.
You know?
فين رايح اساسا؟ فين راح؟ اي الحين حشغل كل شيء. ابغى بس تليفون هنا يوريني ايش اللي صار هنا. ابغى هذا حقك حيكون شغال على طول، بس ابغى يوريني ايش اللي حاصل، ايش بنشوف. اوكي that's good. Am I online?
Yeah, we can hear you, Emad.
Okay, thank you, Majid. So I just need to have the other camera pointing towards me. So we have a 30-year-old male patient, has no significant past medical history, who basically seen in my clinic for the main complaint of having heartburn. He has actually followed every single lifestyle modification he could achieve. He wasn't that obese to start with. He wasn't an alcohol drinker. He wasn't a smoker. But he GERD, heartburn, reflux, and night aspirations or nocturnal aspirations have been interfering with his night sleep, daily productivities. He always feeling tired. I started giving him PPI, proton pump inhibitors, at the highest dose possible, and basically it controlled his heartburn. However, the feeling of regurgitation and nocturnal aspirations could not be helped, and he did not improve. He still complained about this. So between the surgery and the endoscopic fundoplication or endoscopic anti-reflux procedures, he by all means, as the patient that Majid had, wanted to go through surgeries. He wanted to just proceed with the least invasive procedure available. And I did the scope for him before this time. I confirmed that this patient has Hill grade 2, basically no hiatal hernia. So we're going to start with this first to see what exactly we proceed. I have Dr. Hamza with me. He's one of our GI fellows. He's F2, and he's going to share with us today the procedure and help me out. So Dr. Hamza, please proceed. So Majid, if you hear me loud and clear, we're going to switch to the endoscopic image where we can confirm that the patient is a good candidate for this procedure. Can we switch? Yeah, this is the endoscopic image. Giving the tongue at 12, maybe at 6 here. Go ahead.
Yes, we hear you and we see the image as well.
Okay, so let's switch first. Let me help you with this position-wise. And we're going to go. Okay, so the tracheal tube. There we go. So we are in the esophagus. Hamza, take over. So we are in the esophagus now. We're going to clear the lens. You can see that esophagus, proximal esophagus, has no changes that are consistent with chronic GERD, which is very common in those patients using PPI. That's why, in case if you are considering scoping a patient with a history of GERD, you may actually need to discontinue the medication for at least 2 weeks. We clearly see the Z line here. At best, I would describe it as regular or irregular, but no evidence of esophagitis or Barrett's esophagus going into the stomach. It's very important that you know where is the location of the Z line, which is here at the 35. So just to confirm that, it is at actually push in more. It's actually at 37, 38. All right, so go in. Stomach is empty, nice, no food, particles, and mild diffuse gastritis. Get appreciated as well in the endoscopic image. Proceed.
So Emad,
far we have.
You give
Yes.
antibiotic prophylaxis before
Absolutely,
the
absolutely. This is one of the procedures that may entail an incision. I usually give antibiotics for this. And this patient, he has received already ciprofloxacin, and he will continue on that for at least another. Some may give actually cetirizolin as an antibiotic and continue with augmentin, which I usually do as well. So now Dr. Hamza is showing us the antrum. What's your practice, Majid? Is that what you do as well, right?
Yes, we typically give antibiotics to
Okay.
and we see that the patient actually supine, which is the ideal position for.
Yes, correct. Absolutely. Prof. Bhandari, any comments so far?
It looks good. I mean, I'm very impressed with the quality of the gastric mucosal visualization. Normally, you see a lot of mucus, bubbles. So this is good because one of my other agenda is to improve the quality of gastroscopy. We do miss a lot of lesions in the upper GI. But it looks like a good candidate. Once you perform retroflexion, we will know.
Yes. Yes. So that for sure.
Eagerly waiting for that.
Right. So we are doing that section. We're doing the retroflexion. Now we're gonna actually explain how we do the proper retroflexion examination to evaluate the cardia, fundus, as well as
Emad,
the health grade.
can I just make another
Oh,
comment?
absolutely.
The good thing to notice here is I don't see any bile in the stomach. So this patient doesn't have biliary reflux, and that is again an important observation to make. Oh gosh, a very nice retroflexion. So yeah, please talk us through.
Yeah. So thank you, Pradeep. This is actually the very important point that you have mentioned, which is the bile reflux. Could be confused sometimes between acid reflux and bile acid reflux. And yes, I concur. The stomach is actually free of that. Here we see the cardia actually on the left, the fundus on the left, the cardia on the right, where the scope is coming through. And you could appreciate also the Z line and some tissue from the esophageal part. Now we continue to insufflate. I usually insufflate for no less than 90 seconds before I see the whether the patient has hiatal hernia or incompetent valve or anything that would add more information to the candidacy of the patient. So far, he is actually falling, and you could see the flattened G junction here. The Hill grade, the angle of Hess is actually flattened as well. This is falling in Hill 2. If I insufflate more, you will see the valve opening. Keep retroflexion. Keep retroflexion. Okay, so rotate more. You could see the scope. Okay, there we go. You could see that there's some incompetency of the valve as we insufflate more, and this is very ideal with Hill grade 2. Would you agree, Pradeep and Majid?
Yeah.
Yes.
Okay. All right, so now we confirm that the patient is a candidate. He's ready. No fluid particles. Nothing would preclude him from having the procedure right now. We're gonna take the scope out after we push
So Emad,
a guide wire. Yes. So
Emad, before you go, can you go back to the next view and tell us where would you put your sutures?
So okay, go back. So I wish if I have a nice pointer. So we put it at 3 and 9. So as you can see here, rotate more. So this is the, okay. Let me just hold the scope for a second. Let me hold the scope. So basically, we maintain this position right here. So this is basically the great curvature, the lesser curvature. So this could be a very nice area where I actually retract the tissue using the helix device, and the other one on the other side. Actually, here and here. Once I have the device in place, it could be much easier to orient. But it's a gastric plication. So as long as you have a good bite, you will be able to narrow the valve and reconstruct the valve. So one thing I have to mention that the GERDX device is pushed over a guide wire. Now, first, can we have the wire? Yes, this is a stiff wire. Okay, let's have it. Still, we have the endoscopic image. Any question from the audience? I know that Majid, do you hear any questions coming through or?
So please, if you have any question, you can just type them in the chat window.
Okay. I'm actually not holding it. Can you see the chat window or no? Maybe the IT team can help with this. Can you take a picture? Okay. So let's push more as I'm doing this. I'm gonna.
You can see the endoscopist view now, but you don't see the endoscopy. Yes.
View. Okay. Okay. I'm gonna show you the device in a second once I pull this out. Okay. Help me here. Okay. Hamza, just hold the wire. Okay. So I made the exchange very nicely. And here the scope is coming out, and I'm gonna show you. Hold the wire in place. I'm gonna show you the device in a second. Ahmed, please help me with that. Okay. All right. So if we have the room view, please enlarge. Okay, there we go. So in hand, I'm holding the the GERDX device. As you could see here, it has basically the. Can you zoom in? Okay, now it's turn the lights on, please. Let's see if we can actually have there the switch. Yes, there. Okay, that's even better. That's even better. So no, it's this is the actual device we're gonna use. It's loaded already. So it has the knob that controls the retroflexion. When I push the scope inside, this is the way it retroflects by holding the knob to the maximum. So you can actually choose your orientation like that. It's easy controlled, nothing fancy about it. And it actually has the locker in case if you want to keep it in position. Most of the time, I don't need that because it's actually fairly stiff to stay in position once I switch it. So basically, and then after that, as Dr. Pradeep mentioned, the handle is very easy. You can use the both hands. This is the fire, or where you can fire, and it has a nice labeling on top of it that shows opening. You can just lift the switch up and push it all the way. And once you put the switch in that position, you can easily open the arms like that. So that's the way it opens. And then once you're in position and push the helix out, this is how you push the helix. Yep, that's the helix coming out. Trying to show you here with the camera. Helix in and out, and that's how you retract the tissue and bring it back between the two arms so you can have a nice bite. Once that's achieved, you can switch to closure, the nice lifting, and then all the way to the closure. And that with squeezing the switch will close it. And then I'm not going to fire because it's already primed. You switch to fire and you fire. And once you do that, you can just redo the cycle by opening and reloading. So after you pull the device out. So and this, it has a small port where you can actually push the neonatal scope or the slim scope to visualize. So using the wire that we have already introduced, the guide wire, I'm going to close. Ahmed, do you have the sutures themselves? I just want to show them. That's the way they look. Perfect. So that's actually the head with sutures already preloaded, and you can just mount it and pass it down. Okay, thank you, Ahmed. So using, Ahmed, can you help me holding it, please? Just gonna push. So I'm gonna use, be careful here and be sure that you slide the guide wire through the two holes of the two, okay, just give me 1 second. Here it is. And from that, we push it through the small channel to get it out. Okay, small canal. All right, so that is done. And that's how we gonna, sorry, give it back. There we go. Thanks, Ahmed, for your help. And then we push it through. That's how we can also use to, once you get the wire through. Okay. It's very soft at the tip. There's nothing to worry about, no trauma. We just make sure like we pass it over the guide wire. Give me the negative tension there. Gel, little gel here, please. Okay, she'll have a little bit. Okay. Oh, I'm sorry. Okay. There we go. Yeah.
You routinely deflate the ETT tube balloon.
We are about to do that, Majid. Nice point. Okay. Okay, see straightening. Can we deflate? Anesthesia. Can we deflate the endotracheal tube, please? Thank you. Here we go. Okay. Just like that. Okay. Okay. Give me negative tension. Negative tension. Just no, not yet. Not yet. Okay. 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 Now it's better. Not yet. Not yet. Not yet. Give me 1 second. Give me 1 second. Not yet. Give me 1 second. I will tell you once I'm down. Okay, okay, okay. Okay. Now you can inflate, yes. Yes. No, I'm on gonna out, no need, but on the way in. So let's to push the scope down now. Give me the scope.
So as Dr. Emad was doing, it's critical to be patient and
Yeah, not
know
force
in
pushing.
advance in the
Totally
device.
agree. Totally agree, Majid. This is very
No
important device.
problem.
This is very important advice. And now I'm just going down to check the position. Once you push the scope down, and once you put the machine down, the device down, sorry, you don't need to basically, okay. Just let me adjust your scope position. Okay. Okay. Just come on this side, it's even better. Okay, give me 1 second. Inflate the stomach, inflate, give me more air. More air, good, good, good. So we're just gonna take our time orienting ourselves here. It seems that devices, let me rotate and just, yeah, that's the bigger. Now we can just go push the scope down, push the scope down. There we go. So we are in position, good position. So yes, yes. Now go give me, hold the device for a second. Let me just retroflex. And, all right. So the difference between this device and TIF, the GERDX and the esophagus, the esophagus, you don't have to actually pull the scope out or something to readjust your wheel. So here you can see that we achieved the nice position. Retroflex more, retroflex more, retroflex more. Adjust your position. خليك معي كده. أيوة like that. So that's the first nice position we have. Insufflate more. Insufflate more. Okay, good, good. So that's a good one. So now I'm just gonna open to allow the helix and even do more retroflexion. I'm gonna lock it at this point. Yes, good. So pushing the helix out, choosing my spot. That's a nice spot. You could see there. Stay in position. I am controlling it. All right, that's maybe too acute angle. That's even better. Okay. You stay in position. Don't move. Don't move. Don't move. It's very stable. It's very stable. You don't have to really worry about doing too much maneuvering as you are. Okay, now we are actually getting the bite, opening a little bit more so I can retract it even better. And that's once you are actually taking the bite, just bring it closer to you, closer to you, closer to you till you feel like actually grabbing the tissue. Thank you, Ahmed, for your help. Now, once you're actually you pulled it deep enough towards between the jaw of the device, you can just lock it as we did so you can secure the position. Again, it's gastric plication. So once you are actually in position, you can just do that positioning. You're happy to go. And you can, if you make a wrong bite or you're not happy about the bite, you can just open it. You don't have to worry about this. So here, I'm actually, just to show you it better, this is the helix inside between the two arms. And the bite is ready to be taken. But before that, I'm going to close to assure that deflate so we can get enough tissue. Deflate more. And that's, okay, no, stop. Okay. So that's first, it's closed. And we are ready to fire. As you can see, I just need to switch to fire mode and then we deliver. So that's the first. So inflate, Hamza. Inflate. Yeah, I'm gonna loosen the helix and slowly open. Inflate. Okay, that's it. Inflate, and nicely open. So simple 3 steps forward. I didn't have to sweat it even. Okay. So Majid, Pradeep, do you have any comments so far? So that's the first bite taken.
We see. Go ahead, Pradeep.
Oh, it's very well done. I agree. I think showing the value of deflation, very, very important. The more you deflate before you fully close, the more bite you will get, the bigger the flap.
Reflex more,
So
reflex.
very well done.
Okay, so that first part is done. So we're gonna reload before we be ready for the next one to fire. But you could appreciate how nicely it is. We made it tight, we made it nice. So I'm gonna just close first before I pull the device to reload it. Like that. And you know what? Just make sure, you know, it is loose and you don't have the lock on, and you can just pull it. No, it stays. It's okay. Stay. Gentle. Yeah. No. Oh, I'm straight. He's straight. And loosen, and pull. Yes. Loosen and pull. And then we pull my device as well. We are just ready to go the second time. There we go. It was very straightforward. Nicely done. Okay. So we're going to reload it before we go down again. So why did you go in and put the wire, please? Go. No, we're not done yet. Why? We're not done yet. So there's another bite. Oh, yeah, sure. Yes, let's go. So till we get ready for that. So I'm going to show you how to load the other suture, which is fairly simple. Hamza, just give me some room. So Ahmed, please come forward. So first, same thing. So help me, please. So we open it first, and then we mount them one page. Let me hear the click. Yeah. There we go. Ready. That's it. Fairly simple. Nothing to worry about. And then we close it. And it's ready. I'll put it here. The guide wire. Any questions so far before we do the second part, which is also straightforward, nothing to worry? Dear Majid, Pradeep. I know this is kind of super easy, boring for you guys, but you know, it's nice to show.
I think you demonstrated it very well, Emad, and as Pradeep mentioned, it's very important to deflate to get a good capture of the tissue, and then to pull the scope toward the G junction and to get more tissue into the device. And they have done this very well.
Thank you, Majid. Thank you, dear Majid. Prof. Pradeep, thank you for being with us today. I know I have seen you not too long, almost 2 days ago, which was a pleasure to see you. And just to re-stress on the point, I would not miss Endo Port. Please join us in this great meeting that is being held by our greatest pioneer, Dr. Pradeep, Prof. Pradeep, which is going to be in May, right?
In May, yes, please.
Yes.
12th to 14th of May. So come and join us on our coastal seaside. It's not as beautiful as Jeddah, but still the sea is nice and weather
It's more
will be nice.
beautiful. It's more beautiful. Absolutely. We wouldn't miss it. Okay. Now, pull.
So question for Pradeep, how many sutures do you put? Do you put like 2, 3 more?
I don't think I've ever done more than 2, but it is possible to put a third one as well. And I know lots of people who've done the third one.
I have done the third. And today maybe we will, if I feel there is a need, I would put the third one. The company won't be much happy with that, but I do my best. Okay, so can I have the... Oh, sure. Keep me looking for it. Sorry.
I think you did the intubation quite well. Sometimes you might have to dilate the upper esophageal sphincter before we put it down. But most of the time, if we are patient and if your anesthetist can help you with jaw thrust and deflating the balloon, it goes down without any problem.
Oh, absolutely. I sometimes need to do the bougie. I have savory balloon, savory dilator.
Yeah.
Okay, so we are feeding the device now. Okay, there we go. Give me some gauze, Mark.
So Emad, do you discharge patient home the same day, or you let them stay
You know,
overnight?
Majid, I really think that there's no much need to keep the patient in-house, but it's a trend that I have been doing with all procedures that include some sort of intervention. When you talk about,
So,
you know,
Emad,
yes,
if you could you demonstrate to the audience, if you just take it out 1 second, if you
sure,
could pull
sure.
the device out, ask
Okay,
your assistant to just rotate the knob to flex to see which way this will flex.
okay.
Which way does it
Flex,
go?
flex, flex.
Just tiny bit to show the, oh, there's
This
somebody
way. So,
standing in front, so we
okay.
can't
Can
see.
you just so this
Yeah,
is the
yeah,
way
yeah. Thank you.
this is the way
Yeah.
it flicks. The normal anatomy orientation.
Exactly. So do you see that, guys? This is why the position of the handle, the way you intubate, is decided by this. So
Right.
this is how you need to hold the handle. This will now automatically go along the curvature of the esophagus. Thank you.
Easy and nice. Yeah.
Yeah.
All right. So we're gonna do that. We're gonna push, push, push. Nice and easy. And again, as Majid mentioned, do not force it. Just take your time with this. Deflate the balloon, please. If it's not deflated, okay. So make sure it's deflated. Ask some help. No need for action. Just gentle, gentle while they're exchanging, and then nicely pass through. And then we do the scope part. Thanks. Lubricate it. Thank you. We're gonna push it down. Hamza, come on my side, please. It's okay. Once you face the stomach tissue, just insufflate, and we will make the orientation. There we go. Okay, push the scope. Push the scope. Push the scope. Okay, go there. This direction. Okay, retroflex. Go and retroflex. Gentle, 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 gentle. Okay, insufflate, insufflate, insufflate. Okay. This is normal amount, small amount of bleeding. This is not a big deal. I'm just gonna retroflex at this point.
Looks very good.
Yeah. Right. Yeah. Try to adjust your scope because your scope is the one not. Okay. Okay. Stay away. Okay. Hold the device for me. I'm gonna help you with this. I'm gonna help you with this. Okay. Stay steady. Mark did not lubricate it well, which is okay. It's okay. Mark, listen. Okay. Okay. Hold it. Hold it. Hold it for me. Hold it for me. All right. That's okay. Just taking my time to reorient myself, making sure like we are the right position. Maybe it's okay. I understand what's happening now. I'm gonna make it straight. Rotate. Okay, there we go. So I am in position now. So I'm gonna take the bite on the other side. Rotate the other side so I can. Yeah. انت خليك مع okay. Rotate. Yeah, go on the other side. Go the other side. Yeah. No, no, no. Not like that. Not like that. Not like that. Do you see me? Okay, I'm gonna rotate this way. You go the other way. The other way. The other way. Okay. There we go. It's very important that your assistant just take your time. So, no, no, no. Wait, wait, wait. There. All right. Okay, perfect, perfect. So, all right. Now I'm in a good position. I'm gonna do the same thing again. Trust me, guys. It usually takes much shorter than that. It doesn't take that long. But because we are like taking our time, explaining things, walking you through it, give me good visualization so I can see the helix. Rotate more. Okay, perfect, perfect. That's perfect. Okay, now we are ready for the second one. So I'm gonna loosen the helix. It's always okay to take your time. Loosen it more, like that. Yep. I like to take it even more. Okay. Okay, yeah. I'm gonna track a little more. Help me with little section, not too much, just little section, little section. Oh, sorry, that's too fast. Okay. Give me, Okay. Not too much. خليك زي ما انت. Okay. Lock it. Okay, it's locked now. We're ready to have the second bite as you are. Don't move. You don't move. I move. You stay as you are. Stay as you are. Stay as you are. No, don't move. خليك زي ما انت. Like that, yes. Okay, so we are ready to go. Yep, as we are. Okay, so now I'm ready to close to take the other bite. Deflate more. Deflate, deflate. Okay, ready. Nice bite. And then, okay, so we fired already. Okay, it's fired. Fired. So we're gonna close slowly. Open. Open. Okay, we loosen the helix. Inflate, 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 inflate. Insufflate, insufflate, insufflate. There we go. I'm gonna loosen it so we can see what's happening. I'm gonna retract my helix. That's the second bite. So I feel like maybe I'm gonna reassess before I consider. Can I have this device, Ahmed? Hold it, hold it. Let me see. Let me see what's happening. Okay. So I'm gonna examine to see the area. I feel like we have a nice fundoplication. Just gonna insufflate more. See how it looks before I pull the device out. Okay, regardless. So we may have a better image actually with pulling the device out. So I'm gonna pull it out, loosen it, then have a nice look with the regular scope. Let's pull this first. Hold, loose. Make sure it's loose. Yeah, okay. Okay. So that's all good. So let's go again with the scope, regular scope. And so far, before we get to the final picture, using our gastroscope, any questions from the audience so far? Majid, nothing in the chat box? Any comments before we have the final picture?
I think it looks
So
very
you don't
good
need
to me.
you don't need CO2 insufflation for this procedure, Emad, right?
What's that?
You don't need CO2 insufflation.
I always use CO2. You may choose not to go with it, but for all procedures, I prefer even a simple colonoscopy. I use CO2, especially when I have plications, incisions, like we use in endoscopic sleeve, as well as when I use the GERDX device or DuPont. I mean, those have good indications for CO2, but to the patient comfort, I get used to this. I feel like it's much more convenient to have it. As Dr. Pradeep mentioned, Majid, I just want to mention something before we do the retroflexion. You could see here, I'm just gonna wash it, how the area of the sphincter become tight.
Yeah.
Yeah, very nice.
It's actually much more competent than before, as you can see, and this is appreciated at almost 40 centimeter. The last Z line before the plication, it was actually at 38. This is all normal bleeding. It's nothing to worry about. As you could see how long sphincter has become with a nice plication. That's very beautiful. I really, really, I mean, for someone like myself doing both, TIF using esophagus and GERDX, I think at this point I don't feel any much difference.
Yeah. I think you're going to get a very nice flap valve here. You can see how this thing will become a beautiful flap valve.
Perfect. Perfect. Yeah. Well, that's the end of our procedure. And I'm just gonna change and join you in the closing remarks. And if you have any questions, my dear audience, we'll be more than happy to answer them. We have Prof. Pradeep and Dr. Majid as myself. And see you in a minute or two. Let's go on
well
break.
Done, Majid.
Thank you, dear Pradeep.
Beautiful demonstration. Thank you. Excellent. So I was going to ask you, is this device and procedure now available under national healthcare system, or is it only available for private patients in Saudi? Do you know?
So it's actually available for both public and private, but not all public hospital have this available. So it's available for public as very limited
Yeah.
number. But most
Because,
patients that we did are actually private patients.
yeah, because in public hospital, you probably have to do a business case, justify why you want and all that. So it will take a long time to get
Yeah,
it
we have
on
to stop
shelf.
doing everything else and just do GERDX.
Yeah. Yeah. Now, I think also it will be good to create awareness in the public to take reflux. The reflux,
Yeah,
they don't need to live with reflux. The reflux can be sorted out.
Can you give me a host?
absolutely.
Yeah.
Okay, so Pradeep,
Uh,
Majid, I'm back. So I think at this
Excellent.
point, let me see. Okay, let me close this. How can I close this video? Stop sharing from your end.
It's a
Okay.
very good demonstration, Emad. Very nice.
Thank you, dear Pradeep. So really, we had a great outcome today with this anti-reflux endoscopic device. This is a new era that where I believe the chapter of management of GERD has been changing on a monthly basis, and it's gonna change, as you mentioned, Dr. Pradeep, that things gonna change even faster. So we shared with you today our experience using GERDX device. I really thank Prof. Bhandari for joining us. I know it's at a weekend there. Very lovely back seeing through the window. I'm sure he's eager now to close this and start enjoying his weekend. I'm not going to hold you any longer. It seems we don't have much questions in the chat box. Majid, thank you so much for joining us today as well, sharing your experience, as well as a great talk about how and why do we need to treat GERD. I think moving forward, this is another tool in the arsenal of management that should be used wisely as indicated, and not for everyone. Still, if I may say something, we still need to go through algorithm and protocols of the management of GERD, lifestyle modification, trial of PPI, definitely the lowest dose possible. If you could keep the patient on that, it's even good. But if you can't, always consider doing an endoscopic anti-reflux procedures with it, whatever device you're going to use or prefer, or the patient even choose or prefer. And don't forget that surgery always plays a major role in fixing the anatomy if the patient has a large hilar hernia. Starting with Prof. Bhandari, then Majid, if you have anything to say before we end this event.
No, I only want to thank you and the team to putting up a very good show. I think in a very short time, we managed to cover all the intricacies of this procedure. So I like the format, and I'm sure this is going to be appreciated by all your audience, that in a short duration, we discuss everything, and then you go and see. So well done. I'm really pleased.
Thank you. Majid, dear Majid, anything?
Thank you very much, Emad. It was my pleasure to join you today with Prof. Bhandari, and really enjoyed your very nice demonstration of the case. And we have already entered a new era of endoscopic GERD management. And thanks for this workshop, increasing the awareness, the knowledge, and the skills as well.
Thank you so much. Thank you for our dear audience and guests joining us today. And looking forward to see you in more live sessions of Endo Orbit Education. Thank you and have a nice day.
Bye, guys. Bye.
Take care.